recording this session. There we go. We're recording this session and we will share it with everybody who has registered for this session afterward, because this is part of kind of drawing together a learning community to learn from each other and also to learn from experts. So we are going to be covering, or Dr. Vigna is going to be covering, findings from the 2019 Behavioral Health Gaps Report. And Julia will put a link to the report in the chat. We've also received it in the invitation. And then after Dr. Vigna speaks, there will be a brief opportunity for questions. So if you have questions about the report itself, then there's just going to be an opportunity. You can either put those questions in the chat as she goes along, or you can raise your hand during the Q&A. And then after that, we're going to ask a panel to speak to us from their perspective about disparities, what's going wrong, potential solutions, and how we can all work together to make this all somehow work better. And so those panelists are Dr. Ginlack, who's the CEO of Serenity in Milwaukee. He's a licensed clinical social worker. Dr. Kajua, who is an associate professor of clinical sciences at the Medical College of Wisconsin. She's a pharmacist. She also practices at the 16th Street Clinic in Milwaukee. And then Carlos Frick, who is the advocacy director for NAMI Racine. And then after the panel speaks, then we'll open for open discussion with all of you to share your thoughts and ideas and questions of the report and whether things have gotten better or worse since then, and your experience in barriers to equitable access to mental health care, promising programs to improve cultural responsiveness and address inequities, and then any kind of, we call it an MHAP, low-hanging fruit. Those are like short-term policy recommendations that we can make or models that we can scale up to address this, because we know there's excellent practice happening around Wisconsin, and sometimes we just need to know about it in order to replicate it. So before I introduce Dr. Vigna, a brief word about MHAP to those of you who are new to us. The Mental Health Action Partnership is a new and it's sustainable. It's like for the decades, statewide mental health coalition representing peers, family members, providers, administrators, policymakers, and allies across the continuum of care and across the lifespan and throughout the state. So we're working together from our various perspectives to advance ongoing mental health system improvement throughout the state. MHAP meets quarterly for summits. In the cold months, we meet online, and in the warm months, we meet in person, because in person is always better. So our next summit will be May 22nd in Wausau, and we hope you can join us. Julia is going to put a link in the chat for registration. Then we also work in smaller work groups to hammer out recommendations and for public policy changes, and also how we will work together as a partnership in order to raise the voices of those who may be less heard, and make decisions, move decisions forward to change the system. If you're interested in joining us, please register by May 3rd, if possible. That'll help us a lot with our meeting logistics. And then finally, learning sessions like this today are MHAP's way of creating community, a learning community where we can learn from each other and from the experts about what we need to know to inform our work. So now it is my pleasure to introduce Dr. Abra Vigna. If you have questions during her presentation, as I said, put them in the chat or wait for the Q&A afterward. Dr. Abra Vigna is an action researcher and evaluator for a decade of experience working to advance health equity via direct service, coalition building, and community-engaged action research. Trained in human development and family studies, Abra received her PhD from UW-Madison School of Human Ecology and has expertise in adolescent health, gender and sexuality, health equity, contemplative science, and child development. So Dr. Vigna, please share your thoughts with us.
Thank you all so much for having me today. Let me just get my screen synchronized. I am very excited to be here. Frankly, I'm just really excited that you all are doing this work. Sorry, as I shrink up my guy here, so I just have my slides in the way. Almost, we're almost there. The GAPS report is a few years old, and if any of you have actually wandered to that link and read through it, it is mighty, so well done. And I'm going to do my best to get us through as much of the relevant data as possible, but I highly encourage you to take a peek, critique, what have you. So oh, nope, I'm not fully on screen, am I? In summary, all right, sorry. In the end, we wound up doing 39 interviews with key informants that were typically at the administrative level, both at the state and then in charge of behavioral health services. So maybe they ran an organization that specialized in outpatient services or inpatient services. And then we, through a subcontract with Ubuntu Evaluation and Research, which is a Black woman-owned and run evaluation and research group out of Milwaukee. They conducted 11 focus groups and workshops across the state, speaking with Black and Brown folks, Indigenous folks, LGBTQA, trans, intersex, non-binary, gender expansive folks, adolescents, folks that were houseless, and folks that are identified as deaf or hard of hearing consumers. And then beyond that, we utilized the state listservs to invite practitioners to complete surveys. And in the end, we had 1,816 surveys that were at least partially completed by providers and advocates. And all of this was created with the guidance of an internal advisory team. And the key stakeholders were identified for the in-depth interviews by that internal advisory team. And those folks were selected because of their broad view or like eagle's eye view and experience with the system of behavioral health and with its actual administration. And but we did our best to find a balance of perspective of folks that practiced or lived in both urban and rural areas, that worked in youth and adult services, public and private behavioral health services, and that had statewide and local concerns. So throughout the report, we really tried to uplift and amplify what we heard from the consumers throughout those focus groups and to triangulate between those who provided those more systems level that were more administrators with those who are on the ground and really working with people as well. So for this presentation, focusing largely on those concerns that were expressed across the board, but most clearly and keenly by, of course, the folks that are attempting to be consumers of the system, to navigate it, to access it, and to be served by it. And those are the folks that we heard primarily through the focus groups. So some strengths and limitations of the GAPS analysis, because every method has its limits. The data is actually pretty impressively diverse, but it is skewed toward community outpatient service perspective. So because whenever you're doing equity research, you can't just say well, the most people had this concern because, well, oftentimes the way that our systems are structured, the people that have the most people that we can get a hold of easily to provide data are not directly impacted by the inequities or are not contending with it. So it's important to remember who we're hearing from. And even though we heard mostly from community outpatient service perspectives just by sheer numbers, we still heard a lot of the concerns about inpatient services as well. And of this, that means it was 61% of the survey respondents identified as being in community outpatient services, and 43% of the key informants were most understanding of that. The majority of the views of the survey and interviews were of white, cisgender, and heterosexual women. So even though that's 85%, that is, in the world of surveys and interviews and data collection, still impressively diverse. And whereas the focus groups and workshops were majority Black and Brown folks, or Black, Indigenous, and people of color. So we asked folks a number of things. We were primarily interested in accessibility, in gaps in services, and inequities. And we asked folks, like, who do you think are the populations that are facing the greatest gaps? And this is an area where you can see some of the limitations.
That is crazy. So you saw what
of how you ask questions, which is that you'll see in the bottom left-hand corner, a limitation was that we asked people to pick up to their 3 top priority populations that face the greatest gaps when trying to access behavioral health services. And we neglected to choose multiply marginalized. So we don't know if folks were indicating this unique population with just this one identity, or if they were saying folks who have multiple identities. But essentially we heard folks with dual diagnosis needing mental health and substance use disorder needs, folks that are houseless, and then young people as well. They talked about how specifically for young people, like we just don't have programs in this area for kids between the ages of 12 and 17. And what's happening is we wait until they're 17 and they fail, and then they're getting involved into programs. And what we need to see is programs that help them during these ages and keep them in school or receiving educational services. And this is essentially that this gap early on in the lifespan is causing more severe challenges and deeper, more entrenched habits and ways of adaptations that could have been perhaps avoided if services were available earlier. But we did hear through the interviews and through the focus groups that the perception that folks that are multiply marginalized are at highest risk, meaning that they are like, well, especially specifically Black and transgender populations, and also disabled or differently abled populations, that just in general, there are few providers that have sufficient education about how to serve this population, and few providers that identify with that are members of these groups or all of these groups altogether. And so there's a lack of understanding about the additional needs that are present when facing so much structural discrimination for identity upon identity. And that how this is related to, we see higher rates of LGBTQ and Black and Brown youth in our houseless populations as well, because there are so many different gaps in various systems, one of which is the behavioral health, that winds up in either not being kicked out of a home or having to leave a home in order to be safe. And there's not any social welfare that sufficiently catches these young people. So from the consumer view of the gaps about services being inaccessible, too homogenous of a workforce and a service array, meaning that the people who are providing services are predominantly white, cisgender, heterosexual, monolingual, only speak English. They're not trauma informed. There's not enough of them. And then there's a cultural mismatch in the services, and I'll go into detail about that a little later on, that there's too much of a risk because people being seen receiving services and the threats that provides within your community, because other people see it as stigmatizing, the view that folks with mental health needs are unstable or inherently more violent or dangerous to be around, is a real disincentive, as so many of you know on this call, to actually go and try to receive services. And then also when there are so few providers within minoritized communities, that there's a lack of confidentiality or a perceived lack of confidentiality. That if they know my business, then they're going to tell everyone, or then everyone knows my business. The default use of the criminal justice system when people are in crisis, particularly if they are darker skinned or are undocumented, just increases criminal justice involvement. And then, as I said earlier, that gap of services in the younger ages, when some of our early adaptations or mental health or use of substances to manage the distress that we're experiencing in childhood really begin to set in, the default is it's not until the person winds up becoming more and more of a problem, so to speak, society-wise, that they're actually, and then their behaviors are criminalized, that they're often getting services, as well as the fear of what will happen to their jobs if other people find out, or if they wind up having to take time off repeatedly to try and navigate the array of services and appointments and what have you. that it costs too much, that it's too far away, meaning that relative to where they live, very hard to get to, that it's too long of a waiting list, meaning that there are shortages in facilities and workforce, and that you don't qualify until you're really struggling. So that speaks to system organization, and that it's really hard to navigate because the system is organized in such a manner that just makes it really hard to even understand where you begin and how you get to the variety of services that you need, that you can't have your mental health and substance use needs addressed simultaneously, but you have to choose one or the other, is identified as really challenging. And that's what we mean by siloed services. And from the providers and the advocates, what we heard is that staff are overworked and underpaid, that the reimbursement rate is just too low to serve people on Badger care in a large amount at a sustainable rate and actually like pay all provider bills just for being in service. And that the process to get reimbursement costs too much in unbillable time, that not enough required activities are actually reimbursable, that it's very hard to attract and retain diverse providers or truly any providers, particularly for folks that have facilities that are closer to the state line of like Minnesota or Idaho or Iowa or Michigan, where the reimbursement rates are higher, or people are drawn into the private sector because, not reimbursement rates, but because they can be paid more. And that not enough credentials are reimbursable by Medicaid. So for example, licensed marriage family therapist, licensed clinical social worker, peer support specialist, what have you. And that the system is too siloed and hard to navigate. So we see overlap there, being that it's very hard to coordinate services. Administrative rules need to be revised or modernized in some places combined. Not enough people are adequately trained to serve duly diagnosed individuals. There are intensive facilities are too few and too far away, particularly for young people and the amount of separation that happens, or for adults with young children. That the county system, the way that that's set up, is in itself a problem, and that there is a need for shared data systems and for more wraparound services, particularly supporting folks that are transitioning into and out of incarceration. And the stigma for seeking services and reliance upon law enforcement keeps people from seeking help, and therefore their challenges tend to deepen before, and then they require more services and there are too few services available, and it's a very unhealthy cycle. So the most frequently reported cause of the gaps is it really does come down to the reimbursement rates. So looking at, we asked folks to hypothesize on the causes of the gaps. And so taking a health and all policy sort of approach and being really explicit, that looks like there's systems and policies and organizational level elements that need to be changed, like the reimbursement rate, the activities that are reimbursable, the siloing of the system, the restrictions on eligible providers, the way the system is organized, using primarily county levy, and the restrictions on facility treatment capacity and underfunded crisis services. These are all, that's one way to approach it. And then the element of stigma against mental health and substance use services, and how that connects to, is fed by, and it's justified by white supremacy culture, and that people feel really ashamed to seek help throughout their lives. That professions and organizations wind up centering whiteness and Western culture in how we conceive of what is a mental illness or what the causes are of why we use substance use, that it's highly individualized and more collective oriented cultures. This doesn't speak to their inherent wisdom around how to heal and how to repair trauma and loss. That hyper marginalized consumers are under more stress with fewer resources, and that includes the lacking the resource of culturally matched providers. And so we heard a lot from consumers that were hyper marginalized of like, I'm already hurting, and if I go in, I'm just going to get more hurt because folks don't understand what I'm going through, and they speak to me in ways that are patronizing or demeaning, or I've been so, I don't trust any system, and these services are also provided right next to child protective services where they said that I was abusing my child, even though I wasn't, or where incarceration winds up happening because of it being like public buildings. And so I distrust that. That is literally the site of trauma. Why would I go there for help? It won't help me. And then we heard about insufficient prevention and wraparound services being one of the causes of the gaps, that there's not enough support for youth, that medical transportation is problematic and insufficient, and that medication in general is sort of the go-to when there are many other ways to manage a lot of behavioral health needs, certainly not all, and medication, I'm not in any way endorsing the absence of it, but that what we heard was that there wasn't enough opportunity for folks to really be active in their treatment plans, and or that the folks that they were working with were insufficiently trained to help support a medication alternative treatment plan. So the priorities for addressing these inequities were recruit and use incentives to grow the number of providers of color and of bilingual providers, encouraging them to join the profession by using grants and reserving funds for subsidizing educational costs, specifically for psychiatrists of color, or for child psychiatrists and child psychiatrists of color, and using funds to support translation services for our deaf and hard of hearing providers in training, as we heard that many of them couldn't wind up staying in Wisconsin because the clinics themselves are in charge of providing those translation services to mediate between a deaf or hard of hearing provider and a hearing consumer, and that they just weren't even choosing to do that. So they couldn't even get their service hours complete in order to get credentialed. Another priority is to build partnerships with historically marginalized communities by including representatives in decision-making bodies regarding the system and service changes that are necessary, and employing community members to serve as system navigators to try and support consumers who are very intimidated or just really have a hard time making sense of these systems. I've been there too, so this is more in the peer specialist or peer support specialist realm. And then increasing provider capacity for trauma-informed and healing-centered approaches for working with historically marginalized populations, and providing provider oversight to address implicit bias. That we heard that a lot of providers will go through like an implicit bias training, or will learn a little bit about how structural racism impacts folks, but that work is really intense to root out all of the different avenues through which racism, sexism, everything, all of the isms use you to perpetuate the world. And so having continual oversight to ensure that the growth continues to happen would be very helpful for reducing the harm that non-marginalized providers wind up causing, perhaps inadvertently. And then investing in crisis diversion alternatives that avoid the criminal justice system, and advocating for collectively addressing the social determinants of health, like housing, childcare, worker protections, as fundamental drivers of mental health or of substance use disorders. So effectively really seeing that all the opportunities that this coalition has to be working in partnership with other coalitions that are focused more in on these, demonstrating that like, hey, this is intersectional. And a lot of our people are having troubles with the behavioral health system, and the behavioral health system is inadequate and probably will never be adequate to address the harm that is caused by chronic houselessness, by this system that prioritizes productivity and extraction over collective well-being. And then shifting away from a county levying funding system to a more regional approach in order to dampen the ongoing inequities that were put into place by segregation and redlining practices. In that, when the county health rankings and roadmaps was putting out which counties were the healthiest every year, it pretty much always aligned with which counties had the most money, right? And so if you can only get health services through your county, well, that coffer is only going to be filled by property taxes within that county, which will only reflect the wealth of that county, which reflects where people were allowed to, frankly, take land, but to buy a house, and have been for the last 150 years. Then for developing the workforce, what we heard in prioritizing and expanding provider diversity, that is recruiting folks behavioral health, creating pathways for career placement and professional development in rural and underserved communities, loan remission, tax incentives, subsidizing those translation services, and allowing and encouraging more behavioral health professionals to provide medication-assisted treatment, but provide oversight to ensure effective distribution of medication-assisted treatment. Because this is where that lack of dual credentiality and also stigma around some providers not wanting to provide medication-assisted treatment because of the one way of thinking that only pure sobriety is acceptable, and anything shy of that is a slippery slope to instability towards criminogenic tendencies and what have you. They talked a lot about how many providers, even though this is a very effective treatment, don't want to provide it. So then when you try to find one, it's hard. But if mental health providers could also do that, that could address some of that workforce shortages. And then really investing in community, including grassroots and minority-led organizations, putting money towards that to really try to expand out the diversity of the workforce in that way. Increasing accessibility by improving the number of providers across northern Wisconsin in particular. And that by expanding the number of folks, the types of titles that can be credentialed, that was one way to put it, expanding the number of positions that could provide medication-assisted treatment, incorporating peer support specialists. Within that, there were all sorts of ideas of like, hey, you already have these people in the area. They might not be child psychiatrists, but they can relieve some of the burden that some of those fewer highly credentialed providers are under, that are creating these really long wait lists that wind up demoralizing people when they go to seek services. Wanting to increase, improve services to medical transit services so that people, particularly in rural areas, can get to what they need. And then one of the recommendations was to pilot the hub and spoke model that we wound up getting. Sorry, I just realized I opened up the one where it's already set up like this. So in 2021, because of this report, they had decided to pilot a new hub and spoke model to improve substance use disorder treatment services in Wisconsin. And one of the impacts, for example, of asking to situate services in the community and not in those public works buildings that I spoke of earlier, like child protective services or the courts, was $5.5 million that was put aside for expanding the mental health system in community-based services, particularly in schools and in peer support services, and providing better access through warm lines and hotlines. Increasing the availability of wraparound services. A piece of that was really wanting to see more like housing services or respite services for families with young people, or well, for families with caretaking responsibilities. As I had mentioned earlier, improving the access to crisis services. We saw a wild increase of that, at least in Dane County, but not necessarily across the state. For countering delays with the stigma that delays help seeking, there was an increase in medication-assisted treatment telehealth expansion, around 1 million, and that went around the state as well. Sorry, I know that I'm running low on time. So for amending policies that put pressure on caregivers or those early in recovery. So these were really like the no-show policies that like, hey, if you miss once or twice, then you're kicked out and have to start with the wait list all over again. Or that the ways in which the translation service certification process biases non-native or native English speakers and not native bilingual speakers. And the absence of family-friendly services. So the piece where like there's a place for your children to wait, or that your children can visit you, or that your children can be in inpatient treatment with you. One of the ways that this was addressed was the award of $2 million towards women's treatment services to try and expand and coordinate opportunities for women to have access residential treatment services and still take care of their families. For improving funding, the rate increases were allegedly to increase in 2022, and that this would hopefully support across all service areas. I'm curious to hear after this section if that actually came to be. I've got essentially a summary of everything that the Department of Health Services did in the forthcoming years, where they cited the report as changes that they made as a result of this gaps analysis in response to the specific recommendations within it. And I will end at that because I'm right at time, just a few minutes over, I believe. Want to make space for questions in the panelists.
Actually, you're doing very well. You're really right on time. Yeah. So this is great. Thanks so much, Dr. Vigna. And clearly, you know, this is an ongoing work. This is going to take all of us over the long haul. And since 2019, we've had a worldwide pandemic. And so that kind of, you know, put a hitch in everything. It was both a silver lining and a problem. So, you know, I would like to open it up now. If you have a question for Dr. Vigna or thoughts on the report, please raise your Zoom hand. We're just going to take a few minutes here for questions about the report itself before we go to the panel. Anyone? Dr. Imler.
Thank you. That was amazing, Dr. Vigna, and such a wonderful job on the report. As I recall, the report was 100 and some pages. In there, I thought there was reference to Medicaid expansion. How much did you hear that back in 2018 and 19?
I mean, regularly, all of the time. And there was also, like, I believe later on that year, the Wisconsin legislature voted against it again. So it was like, as I was typing up
Your free proximity call will automatically hang up in
the response, or as I was typing up the analysis, it was already like bad news bears about that. And so clearly it's definitely a system change that is essential, and one that may be possible now that the state voting lines have been changed from the gerrymandered state that they were in for the last 10 years. And hopefully the work that you all do in advocating for representatives that see how very much the hardworking families all across Wisconsin would greatly benefit from Medicaid expansion will come about in the next few years. But it definitely wasn't one that, like, I wound up highlighting all that much, because it's kind of demotivating when you're like, this is what we need to do, and it was just voted down, and at the time with no real hope for change. But the windows
I think we're in a different place now with the new voting district, so we can really expect a more balanced legislature and probably more negotiation. So this is a hopeful time. Does anybody else have a question or a comment before we get going on the panel? All right, thank you, everybody. We're going to turn now to our wonderful panel, and I'm very excited to announce that we have an additional panelist. I'll talk about her in just a minute. We have a panel of people who can speak to this from diverse perspectives, and I'm going to introduce all the panelists, and then I will ask each of them to speak in turn. So Ken Ginlack, who's a licensed clinical social worker, is a mental health and substance disorder therapist who has worked at all levels of care, including medically monitored patients, youth in out-of-home placement, individuals in correctional settings. And he serves on the Milwaukee County Mental Health Board. He's currently the CEO of Serenity Inns in Milwaukee, working with African-American men. And he has previously worked as the director of the outpatient programs for Milwaukee County Behavioral Health Division. And then our next panelist is Dr. Kajua, who is the founding chair and associate professor of clinical sciences the Clinical Sciences Department at the Medical College of Wisconsin School of Pharmacy in Milwaukee. And she was the first Hmong pharmacist to obtain a pharmacy academia position in the nation. He has over 14 years of experience as a clinical pharmacist with Spanish-speaking patients and serves 1 day per week at Milwaukee 16th Street Clinic. She's a community-engaged health disparities researcher, and she collaborates with leaders across various sectors, disciplines, and lived experiences to create healthier, more equitable communities. And then one of NAMI's own, Carlos Brick, is the advocacy coordinator for NAMI Racine. He's a philosopher and a theologian originally from Venezuela, who has been involved with social causes his entire life. He's a family member and previously worked, before working for NAMI Racine, previously worked as a bilingual advocate in the Kenosha School District. As an immigrant, he's aware of the cultural hurdles minority populations, but especially those of Latin origin, face when trying to navigate service systems. And then we're also excited to have Anna Winton, who's the Director of Behavioral Health for the St. Croix tribe, Wisconsin. She's an active member of the Tribal State Collaborative for Positive Change. The collaborative works closely with the Office of Tribal Affairs in the Department of Health Services Secretary's Office. And Anna is the Vice Chair of the Wisconsin Council on Mental Health and has a master's in social work from UW-Madison. So with that, I would like to turn it over to Ken. Please give us your insight.
And thank you, Dr. Vigna, for that wonderful presentation and for the report itself. As I was listening to the report, I was kind of reflecting on today's time and like when the report was written versus like what's going on now. And I have witnessed some changes that have been made within Milwaukee County, and then there's still some things that I hear in the community, especially when it comes to navigating the system and having access to services. And so that's real big in the community, in the African American community. And it started way back as far as like trust for the healthcare system, the Milwaukee County system. And so not knowing how to navigate services is because individuals have not really believed or trust in the healthcare system for a number of years. And at times when individuals reached out for services, as you stated in the report, there was some pushback, not treated fairly, the stigma that went along with addiction. And something that I would like to point out within Milwaukee County, and something that I saw firsthand when it comes to substance use disorder and individual having access to services or getting into treatment, is that the Black community, a Black and brown community, really didn't buy into the opioid epidemic, or, even though it was hidden across the country. The things that I heard most of the time was that, well, that's only for other communities. That's for the white community. That's not pertaining to the Black community. When it was crack cocaine, it was criminalized, right? The drug addiction was criminalized. A lot of people went to jail. A lot of fathers was taken out of the home. And I heard that for many years, especially in 2018, 2019. And it is starting to change due to the increase of overdose. One thing that happened in the community is that the face of treatment had changed. So there was residential programs located in the inner city, or in the heart of the city, which were filled with African American men, African American clients. And when the opioid epidemic hit, the face of treatment changed, and all of a sudden all the treatment facilities were filled with not people from the community. which caused a pushback as well to say, wow, I can't get in treatment. I don't have access to services. And the reason why is because the priority had shift, and Milwaukee County kind of controlled the wait list. And I'm gonna sum it up. They controlled the wait list to say, if you weren't an IV user, if you weren't an IV user or pregnant or a woman, then you couldn't get into treatment. Well, the majority of the individuals in the community were stimulant users, alcohol users, and so the wait list became longer and longer and longer for individuals in the community to get services. And so the community recognized that and said, wow, we can't even have access to substance use disorder or dual diagnosis treatment. It's starting to shift back now. The county is no longer in control of the wait list for individuals that go into residential treatment. So what happened is when Medicaid started to pay for residential treatment, the residential treatment providers no longer were no longer paid by the county. It became Medicaid reimbursable. So it was a good thing and a bad thing. Treatment providers, residential treatment providers start to control their own list to say, you can get into treatment, or it was no longer regulated for individuals that were IV users. So that was a big shift. Another thing that we noticed, or in the community, last year I did an overdose awareness day. And right in the heart of the city, it was the biggest turnout that I ever saw for an individual, in the community that talked about overdose deaths and Narcan training. So, the community is starting to realize that their family members, their friends, individuals are overdosing and dying, and it's not a racial thing. It's definitely a substance use disorder issue, diagnosis, I should say. And so, with that being said, we are aware, we know that it does affect the community as a whole. Right now, and I have to say this, that one of the things that worry me is that there's a lack of treatment beds. When individuals overdose, and hopefully not an overdose death, but when individuals are looking for services or looking for treatment, there's no beds available. Milwaukee County is aware of it. I mean, the community is aware of it. And we know how essential that is when an individual that's diagnosed with substance use disorder is looking to get in treatment. And so all of a sudden I decided to get help. I want help. I'm going to go into residential. I meet that level of care. And I started to call residential facilities, and there's no beds available. It happens every day. And it's heartbreaking.
Yeah.
Here at Serenity Inns, which is a residential treatment facility, we average 4 to 5 calls a day of individuals calling saying, hey, I need to get in treatment. Do you have a bed available? Do you have a bed available? And we'll do our due diligence to call around to other treatment facilities to see if it's a bed available. Somebody's in dire need. They really need this level of care, only to find out there's no beds available.
Yeah. Yeah.
And know there was a push for, money funded for women treatment facilities. I did a call of action for that. There's a lack of bed for men. We know that it's a higher overdose rate for men, and it's steady increasing. And so I'm gonna end this with a kind of a win, is that right now we're in the process of opening a new men's treatment facility directly across the street from where we're located, which will have 14 additional beds. And so we wasn't funded by the county or the state, but we're definitely looking for Medicaid reimbursement to be sustainable. And so I'll stop right there and pass it on. Thank you.
Thanks so much, Ken. Yeah, and the lack of trust, the justifiable lack of trust in the treatment system, and then the mismatch of policy with the needs of the folks, and then people like your organization who step forward and just do what needs to be done. That's really key. Thanks so much. Now I'd like to pass it to Dr. Lore to speak to us from her experience.
Hello everyone. Today is a good day. Bienvenidos a todos. Hoy es una linda día. And so when I reflect on the presentation by Dr. Vigna, I think of a lot of my Hmong brothers and sisters. Suicide is the #1 leading cause of death in Asian American youth. And she touched on the intersections of various identities. And I also think that piece, that invisible identity of LGBTQ+, and how it can interplay with Asian American and Hmong youth has a huge risk with mental health and suicide as well. It's actually, in my family, there's actually some suicides that have occurred, that in my own family. And so I do wonder, what kind of resources are available, what could have we done, and even the thinking around the hearing that there's like really no programs, for specific age groups, really just makes me wonder what we could have done better, to help in those situations, because I think they thought this is the end, like this is all I can do. And I do see the lack of culturally tailored mental health services, specifically with the Hmong language. So I speak Hmong, English, and Spanish, but with the Hmong language, mental health doesn't necessarily have a word for it. Even the way to speak about health is actually, when you think of health and mental health, it's like, or matters of the heart, but it's actually matters of the liver in the Hmong language. So Kajua is where the emotions lie. And there's so many different ways, right, to understand what health and healing means, whether it be physical, spiritual, to the supernatural world with traditional animism and those pieces. And so I wonder, about those, a curriculum, that we could potentially develop, or a culturally tailored curriculum for our Hmong youth. And so one of actually 3 of my medical students, we partnered with the Hmong American Peace Academy, and we delivered a short, but it's over 4 weeks, compassion resilience curriculum called Show Okay, Let's Stand Together, which talks about different ways to, approach our own identities as Hmong refugees growing up here in America, having that mutual understanding with someone else, understanding what self-care is, what does resilience mean. And I think it's been just profound to just see, Hmong medical students teaching Hmong youth about some of these areas, and how key that is for us to be able to understand our own identities. And then the second thing that I was thinking of when reflecting on the presentation was some of the work that I've done, especially working with Spanish-speaking communities. And I think about even the chronic diseases. So my main disease states I manage are type 2 diabetes, hypertension, hyperlipidemia, main ones. I also oversee other ones as well. I actually just saw a patient today, high blood pressure, about almost 200s, over 100. And is it high blood pressure or is it anxiety? That was what I was thinking in my head. And I saw the patient, I was like, I don't know. Is it that, or is it anxiety? Because there's so many medications that she's taking. Is it also other pieces of the pie, that are impacting the patient? Is it stress related that's increasing the patient's blood pressure? Because I think they have just a lot of a lot of things going on, you know, in their family. And Dr. Vigna's presentation did allude to, you know, the social determinants of health. So is it, you know, someone in their family? I know not this patient specifically, but in the past, it's been trauma that's occurred, you know, within their family. They could be a refugee from, I've had a refugee from Congo to a refugee from Burma, to language and access. I can speak the language, review the medications with patients, but I do wonder, you know, do they have someone that they can go to? What is their support system? Who helps with medications, you know, in the family? And those are kind of the things that I think of when I'm managing high blood pressure specifically too, where stress can really impact patients and patients' health. And how do we also provide those services? And luckily, with 16th Street Clinic, we have referral systems to our behavioral health team here at the clinic. But I am concerned, you know, about chronic conditions and how that's impacted as well. So those are kind of just the things that I can reflect on after the presentation.
Thanks so much, Dr. Lohr. I'm going to try and get you. Oh, there. I'm going to take the spotlight out. You know, I think I'm just appreciating how difficult it is when you come from a culture that doesn't even think about mental illness to try to frame it in a way that you can access services in the system that we have here. It seems like a really big lift. So I really appreciate your thoughts on that. And I think it really speaks to the need for culturally responsive training for all providers, whether mental health or in other domains of medicine. Thank you so much. Now I'm going to ask Carlos to speak from his perspective, his insights. Carlos, go ahead.
Hello, everyone. I mean, there are many places where we can, there are many interconnections, not just within the Hispanic population, but immigrant population in general, so and cultural population. There are many places where we meet. Perhaps the immigrant population has the biggest problem because there are many things that come into place aside of the issues that everybody else has. One of them is immigration status, for instance. Either do they have can they afford therapy? Can they afford medicines? Do they understand the process and the therapy? Do they have access to a therapist that can understand them and that can properly diagnose what they're going through? And all these issues sort of kind of jump on top of the problems that everybody else would have. But we were talking, and the report talks about the need of bilingual therapists. But that is a wishful thing, and that is hopefully something that will change as much as we can allow access to bilingual folk to college and to the career. However, what we have now is what we have, and we see the need, and so perhaps now is the opportunity to start working on cultural diversity, understanding the person that you are seeing. I used to train people on cultural diversity a long time ago, and I used to tell them this example. I'm Venezuelan. I have two names and I have two last names. So my full name is Carlos Alexander Freck Mijares. So if I introduce myself to somebody as Carlos Mijares, they will have an idea. If they've never seen me before, they just write it, they will have an idea about me. But if I introduce myself as Alexander Freck, they will have a different idea about me. And it is that bias that it comes into place because the way I could share my experience, just like the language that I use to share my experience will somehow determine what that other person is understanding about me. And it might be different for, the way that I feel might be different to what the other person understands. And this could happen with any language, obviously. So there is a need to understand, or at least try to understand the individual in front of you, and that involves a lot more than just sitting with somebody. It involves understanding the world they're coming from. As I say, I'm Venezuelan. But I, I could be from Panama, it could be from Colombia, it could be from Ecuador, Peru. We are all different, and it's also understanding diversity among us, because we tend to have this idea that everybody's on the same blanket. It's the same group. It's like culture applies the same to everybody, and not even every Venezuelan has the same, cultural perspectives that I do, because we are a very diverse country. So at the moment, with what we have, I believe that the biggest push should be to understand the individual that is in front of you, and that means getting into not prejudging what the person is feeling or is actually saying, but trying to understand the cultural, the background, what is surrounding that person. The other aspect, and we talked about this before, is the family that is involved with that person, understanding that there is not just that individual, but there is a whole surrounding area of that family. In my own family, well, I'm 52, so I grew up thinking I need to take care of my mother when she gets old, and my mother actually does live with my brother, one of my brothers, and my grandmother, who had dementia. My great-grandmother, who also had dementia, lived with us when I was a kid. So there is also this aspect of not understanding just the person that is in front of you, but understanding the whole cultural, the whole background, the whole family, friends that are with that person that you're treating. And I think that trying to get to that point, again, with what we have, could be life-changing for a lot of patients, because it will give them the trust of thinking, well, at least this person is thinking about me, and this person is understanding me or trying to understand me. And that itself could help individuals, believe that recovery is possible, believe that that person is interested. So I wrap her up with that, but it's again, it's sort of switching a little bit our perhaps a little bit individualistic thought on that every person is their illness, and is thinking that they are all, we're all a group, we're all a villa, and we all need to understand the whole villa. And thank you. And
Thanks so much, Carlos. And you really make a good point about listening carefully, sort of with your whole self and with your empathy and your compassion, to truly understand the person who's in front of you, and the importance of family. In the US, culture is quite, or the dominant culture is quite individualistic, but in many parts of the world, the family is really the unit of identity. People think of themselves in the context of their family. And then the third point you made, I thought was wonderful, was helping young people, or helping people from diverse backgrounds get into the mental health professions, because it's hard to teach culture. You have to come from a culture. So much of it is understood. So that was very helpful. Thank you so much, Carlos. And now I'm absolutely delighted to welcome Anna Winton from the Tribal State Collaborative for Positive Change to speak to us about all of these issues in light of the tribes. Anna, go ahead.
Oh, hi. Thanks. Thank you all so much for having me here today. I feel like I've spoken a lot to some of the DHS staff in different roles on Tribal State Collaboration and Wisconsin Mental Health Council about some of the challenges that the tribes and tribal people have in accessing mental health and substance use care, funding care, across the whole continuum. So I wanted to be here today to learn, and then just some thoughts as I was listening to the presentation that came up for some of the challenges that have kind of been affecting tribes or discussed among the tribal groups in behavioral health the most recently. I just kind of jotted down a list. So first of all, St. Croix, I worked for St. Croix for more than 7 years. So I just speak for St. Croix as an employee, as a manager for behavioral health and trying to help meet the needs. So like most of the other tribes, St. Croix struggles to meet the needs for treating alcohol, stimulant, and opioid use disorders. Struggling to fund residential treatment, and even more struggling to find residential treatment centers in the northern part of the state, a rural part of the state, particularly those that accept the Wisconsin Residential Forward Health Benefit. Particularly, also, we struggle in funding treatment of alcohol use disorders. There is luckily a lot of opioid use treatment money available right now through grants, but I'm sure, as many of you already know, not money for treating alcohol use disorder. And that still is fairly common. St. Croix, in St. Croix, many of the people that need mental health help also need substance use treatment help, and they also have fairly significant co-occurring primary care health issues. So our outpatient clinic tries to help treat those things in a holistic way and not a siloed way, but that can be a struggle. And it also, like I think the report alluded to, means that we really need clinicians that are very well versed in treating both substance use disorder and mental health, and even might know something about coordinating that care with primary care, particularly for our adult and elderly clients. While I'm on the topic of staff, I think because we are in the northern part of the state, although I've heard that it can be all over the state, we do struggle when we have to fill positions with finding well-qualified staff, particularly well-qualified staff that know anything about Indigenous culture in general, or St. Croix Ojibwe culture in particular. We've been lucky right now to have some very good, competent staff, but that hasn't always been the case. And we have also struggles finding places for staff to go. So I really like when it was brought up that, of course, if you're trying to offer behavioral health treatment services in the same place, that maybe there's Indian child welfare services or judicial services, that can definitely be a deterrent. I think some of our tribes, I've heard this from many of the tribes, they struggle in their human services buildings with not having enough offices for people on the other end. And many of our grant funding opportunities are non-construction grants, so there's no immediate way to fix those things. Let me see here. I think one of the things that some of the larger tribes have talked about in tribal state collaboration meetings that might be interesting to this group is that larger tribes that do provide some level of crisis services are not allowed to become certified to provide those services. And then, of course, that means they cannot bill Medicaid for those services. So I believe that's a disparity that should be looked at and potentially addressed in the future. I think another thing that has come up almost continually in the last few years is that tribes are trying to use peer support services and are using them more, particularly as ways to get folks that might have been cut off from their own culture, feel that they don't know how to get started in getting reintegrated back with their own culture. Our peer support professionals, teams, peers can really help them do that. And then that means we need ways to fund them, to pay them a fair salary and to support them the way they should be supported. So one of the things that we have talked about in the past is that right now you can bill peer support as part of a CCS package, but many tribes do not have big enough behavioral health teams or staff to run CCS programs. So until there's some other options for funding peer support services, that is a struggle. I apologize for kind of being all over the place and piecemeal, but those are just some thoughts off the top of my head today. Thank you so much.
Thanks, Anna. We really appreciate it. And I'm really struck with, the need for holistic treatment. Our systems are all kind of siloed, and many of you, all of you actually spoke about, mental health, substance use, primary care. It's all part of the same person, and it's all intertwined, and yet our systems silo those different types of treatment. And then also the place of treatment being a place that people would associate with healing versus associated with oppression. And then the other thing is, I love the embracing of peer support specialists, and then in many cultures, community health workers who are trusted messengers who come from that culture and can help people walk from their context, their cultural context, through to get the help that they could be useful to them from the dominant system. So with that, please join me in thanking our panelists and Dr. Vigna. And now we would like to throw it open for general conversation. And we have some questions that we'll put in the chat, but speak what's on your mind. I could start off with community health workers. What do you all think about La Promotora in the Latin community, or people who, everybody knows these folks? This is a global role where people who are trusted help connect with families, connect with individuals, and help them connect with what they need. Panelists, anybody, what do you think about community health workers in Wisconsin?
I say that's key. I mean, if you are going to connect with the community, you should use the community as it is. Again, I was saying, the family, the people that you can understand and trust. I was saying before that we think of culture as a sort of in a blanket sort of way, and in a way, I'm not going to say that's wrong, but it could lead to bias or prejudgment, but also it assures that there is a common language, that there are common places where we can understand, even if we belong to the same culture or to the community, and we have different cultural aspects. It still allows us to have a level of this is where we meet and this is where we understand each other. And I think that using the community to create that kind of conversation and it is key. It is what's really going to move the needle on the positive side.
Thanks so much, Carlos. Any of the other panelists or Dr. Vigna, would you like to speak to the possibilities with community health workers? Okay.
I think I would, mention I guess I only met one Hmong community health worker. There's not that many, in terms of community health workers that are specifically Hmong speaking. And I think I actually had a conversation with him, and he said there was so much confusion. Do you provide any care? What do you usually do? And that part was like the piece that I think he struggled with in terms of how to advocate for patients as the community health worker person. And then also sharing where the resources are, but then the people like kind of not understanding kind of his role. He's not a doctor. He's not the pharmacist. He's not the nurse. And that piece was really interesting, hearing his perspective, that he was basically like the only one, in the Fox Cities area providing that care and that work. But it is much needed, to help with the navigation of resources and those pieces as well. And how do we also provide support, if you're the N of one, in your area, for the community health worker as well, that's alone doing the work. And those pieces, I kind of wonder about those pieces as well.
Yeah, I'm thinking that
Can I?
MHAP could raise up the, I'll speak and then whoever else said, I think it was Ken. I think,
Mhm.
we can raise up community health workers as a possibility, especially in this era of workforce shortages, but community health workers can play a unique role and peer support specialists can play a different and unique role, and people can get into those professions, their lived experience is what's helpful there. Ken, go ahead.
Absolutely. And so when we talk about culture in the community, um, a lot, and also the African American community, the community, the churches, the supports in the community and the family was a big help. Um, Again, when it comes to peer support specialists, you know, it talked in the report, it talked about reimbursement for being credentialed. And so, we don't put enough emphasis or I guess economic value to individuals with lived experience, and that lived experience will help individuals get that trust back. And so when I talk about trust and how the county and systems look at trust, what better way to do that than to have someone in the community that already utilized the system, right, and already found some value in the system and be an advocate for the system and the work that you're doing in the community. So I really think, it's some value into that.
Yeah, I think that, you can't educate people in context, in that cultural context. That's really something that a treasure that people bring into the work they do. So thanks so much, Ken. I see Bruce has his hand up. Bruce, do you have a question or thought?
And I have just a couple things, and reflecting as you're talking about the community health workers and the people who are effective at doing things, it throws me back to the writings of Ivan Illich back about 40 some years ago. Some of you might recognize that name. I see you didn't see that, but you're dating yourself as about as well as I am. But I also have another hat that I wore, and I was the head of the psychology examining board for a while. And one of the things that I think is always going to be a tension in certifying people for reimbursement is that regulation aspect. The general idea and philosophy behind regulation and licensing is that you have to have mechanisms for protecting the public and for making sure that people don't get taken advantage of, or when they are taken advantage of it, they have opportunities for and pathways for recourse. So that's just another level to also consider in looking at that. I think it'd be really nice to be able to expand the pathways of the kind of people who could provide needed services. But then there also is the part of how to help people who get out of their depth, start dealing with things that they don't know what they're doing when they're dealing with it, and how to kind of create the chains of referrals up to people who have the skills to deal with that. It just makes it a very complicated process.
Yeah, and you're bringing up a wonderful point, which is, regulation is about protecting people. And so, peer support specialists, there is supervision for peer support specialists, but we're not training supervisors of peer support specialists and community health workers. That's a whole different skill set. And, helping people, work through the challenges that they face in their work. And then, like you say, regulation kind of pushes toward people with lots and lots of credentials, and those people with deep expertise are absolutely valuable in the system. But right now we have a workforce shortage, and so kind of opening up the pipeline to get from kind of more entry level positions where you're bringing culture with you into the other mental health professions. In fact, I'd like to throw that open, both the regulation piece and the panel piece. I'd like to throw open to the panel. Anybody on the panel have thoughts about regulations and peer support specialists and community health workers and protecting the public and making sure that people get the expertise they need? Dr. Imler, go ahead. Unless you're, okay, I see Dr. Lohr.
Separate question, thanks.
Leading in. Okay, Dr. Lohr, go ahead.
Actually, it wasn't me. I just leaned in, but I didn't have anything to say. Yeah.
Oh, sorry.
Dr. Vigna.
So for another organization that I was helping out that trains peer support specialists and facilitates like a community of practice to try to expand the leveraging of peer support specialists across the state. When we talk with them about like what their needs are in order to make this more sustainable, certainly a big component of that was like how to best support people that are on their own journey of recovery, which we know is like not linear. And this component where we live in a very professionalized world that is very afraid of like our insurance basically says don't ever suggest that you made a mistake, don't share personal things about yourself. And the whole like purpose of peer support is to talk about how fallible you are and how challenging the system is and how hard it is to navigate and how hard it is to stay sober in a world that's on fire and where so many horrific things are happening all of the time and how natural these things are. And so it's not a perfect fit to put community health workers or peer support specialists, people who are real, into a system that makes us all pretend like we're not fully human, like we don't have bodies and histories and intergenerational patterns and ancestors calling upon us at any given time. And so that challenge of like, this is how I'm told how to supervise. And then I have this person trying to figure out what's the sweet spot of sharing my personal experiences, but not making this about me, like a way for me to continue to work through my stuff. And since I don't even know how to do that in my professional world and role, so definitely that component of needing support to guide it. And also that piece of like, there is like a urge to move towards like the community health workers and the peer support specialists, in part because they're not paid all that well. And it's easier on the system, but this is where we see the repeated churn of direct service providers in general, where these individuals in these roles would be a lot more stable and sustainable if they had living wages, or if universal health care was a thing, or all of the different social welfare components that are that meet our basic needs when we live in a world full of abundance like we do in the United States. I'm just always so worried about that, like trying to pigeon or like to push into an already sort of contorted system, this otherwise really powerful mechanism, and then also not valuing it because in part it's not deemed as valuable. So I think it's like a both and that should be there, and then all that support around. So how do we actually sustain organizationally and system-wide trying to do this work differently, such that I'm not harming my peer support specialist and pushing them further back on their recovery journey, and that I'm not competent, and that I can advocate for them and compensate them adequately and all that stuff.
Thanks so much. And I don't know if y'all are looking at the chat, but there's some very good points in the chat about navigation is not reimbursed by Medicaid, supervision is not reimbursed by Medicaid, particularly supervision of peer support specialists or Medicaid workers. We know that we have the Qualified Treatment Trainee Program out of UW-Whitewater. They spoke to us in our workforce learning session about the need to train supervisors and how their program helps train supervisors. But we also need to reimburse supervisors adequately. The whole workforce pipeline needs to be thought of in a holistic manner. Right now, it's not. Rick had his hand up a while back, so I'm gonna, Dr. Imler.
I don't know how to raise my hand on it.
Okay, go ahead, Ken, and then.
I'm sorry.
Yeah.
I get really passionate about this, and just when we look at it's 48% of Black men that make up in the world, right? And it's only 1% that's in psychology. It's only 1%. Like I'm part of a 1% panel, and I just think society, or even we put everybody in this box of like, this is how you're supposed to act when you're a professional or when you're credentialed. And so I take pride in like using broken English. I take pride in like talking to my clients and meeting them where they at, like talking to them in their language, right? When we talk about language barriers and seeing someone that speak like you. And so that's a big part of the peer support as well. And again, we I don't think we value that enough, right? Because all of a sudden, because I have these credentials behind my name, then oh, you're valid, you're valid to do the job, you're able to protect the people or however you want to spin it, but that always don't secure that validation, right? And sometimes it's a value in not being the stereotypical provider, right? The men that I work with, they love to come in and talk to me and have a conversation because I'm gonna speak to them in their language. I'm gonna speak to them so as they can understand. And so it was spot on when they talk about, creating some scholarships, for minorities that's going in the social services field. It's something that's much needed, right? It's real important for young Black boys to see me with these credentials and working in the field. And so those type of things all start in the community. And I'm gonna be quiet because I get real passionate and yes, thank you.
Well, and amen. And one of the good things about the pandemic is that young people like college students and high schoolers really appreciate the importance of mental health. So I think this is the moment right now to get youth of all cultures and races into mental health care. But particularly it's a really valuable time to reach out to youth of color. Dr. Imler, I know you've been waiting patiently.
A rare thing for me. It was an amazing presentation. I'm so impressed with the comments from the panel. Dr. Vigna, would you be able to show the slide where you looked at the follow-up changes after the report?
Absolutely. Pull that up now. All righty. So this.
Go ahead.
Was there something in particular you wanted to jump into?
Well, what I wanted to point out is a couple of things about the value of the state supporting, this is through block grant monies, a report like this. The report may not have been the only factor, but it could have been a catalyst in some of these wonderful efforts to prioritize these things. So from a policy perspective, and the Mental Health Action Group is kind of looking at the short-term, intermediate-term, and long-term. If we could consider supporting efforts like this was a one-shot. And in a neighboring state, which I won't name, they do it every 2 years. And they support it being in part data-driven. So second point is that the value in having reports like this with recommendations that capture community sentiment is that it can allow for shovel-ready proposals, which this report had many proposals. The third point is just looking at the quality of this report and how broad it was, the number interviewed and surveyed, that the state is hamstrung in many ways by not having the resources. So leveraging academic partnerships. And the cost of this report, I was surprised at what Dr. Vigna and others at UW-PHI did for the cost to generate this level of high quality professional reports. And the last thing is that hearing from Heidi Pankow about the TMG report, a report on needs in 2014, what the Mental Health Action Group in Minnesota did 20 years ago. They didn't focus as successfully on diverse populations, but their themes had many similar elements. And what the Wisconsin Council on Mental Health did for Access and Equity summary, again, not of this quality, but the themes were the same. So my hope is that we have a strong coalition to move great ideas like this forward. There's hope. Thanks.
Thanks so much, Rick. So with that, I'd like to I'd like to say again, thanks so much to Dr. Vigna and to all of the panelists. This has been a really rich discussion. And we are taking the pieces of this and the findings from the report to the Mental Health Action Partnership Summit, which will be May 22nd in person in Wausau at North Central Healthcare. And if you haven't ever been to North Central Healthcare, it's worth it just for, like health tourism's sake, just to see what they've got there. So we would like to invite you all to come. The meeting will be from 9 to 2 o'clock. And Julia is going to put the registration in the chat, you and other people that you know, because right now we're still in the forming process of the Mental Health Action Partnership. But this particular meeting, all of those work groups have been beavering away at recommendations for what we call low-hanging fruit, which are like short-term policy recommendations that we can make to the Department of Health Services and other departments of the state and the governor to get into the governor's budget and go, okay, if we want to move the dial, these are some short-term ideas that we can do. Now, Medicaid expansion is a big idea. We'll push that one too. But there are a lot of these things that we have been talking about today and in our previous learning sessions that we can push forward. So please join us. This is very much a consensus coalition. Context voices, context experts are as important as content experts, and we're trying to move at the speed of trust so that we can all pull together around this. And I think that as we do, we will make progress in the mental health system in Wisconsin. So with that, I would like to wish you all a happy Friday. Enjoy this beautiful spring weather. It may not be spring all along in Wisconsin, but snow next week. So go out and enjoy the weekend and do good work and keep in touch. And I hope you can join us. Oh, one more thing that I forgot. In our learning session, we're going to have a learning session on June 21st. So mark your calendar, another Friday from 2:30 to 4 on Medicaid. And just so, what's the importance of Medicaid in mental health? Just to kind of level set. Maybe you know a lot about Medicaid, but we've been talking about Medicaid, whether you know it or not, in the way things need to be reimbursed here. So come, bring your friends to these learning sessions and join us on May 22nd and join us on June 21st. So with that, a wonderful weekend, everybody.
Thank you.
Thank you. Thank you so much, Ken. Thanks so much, Carlos. Thank you, Anna.
Thank you, Zita. Thank you, everybody.
Thank you.
Dr. Laura, I think she's gone.